Hi, this is Brian Kim. I'm going to share with you this case of a patient who was referred to me. This patient had a complicated cataract surgery, posterior capsule rupture, lens fragment loss into the vitreous space. So the patient had a pars plana vitrectomy by a retinal specialist, as well as lens fragment removal, and was left aphakic. And so after a period of healing time, this patient was sent to me. And so you're going to see this patient has a little bit of a borderline pupil and how I navigate around that. And I'm going to go over a stepwise explanation of my Yamane technique using the Sensor IOL. Again, I prefer to externalize a leading haptic through a contralateral limbal incision. And I do this using a 25 gauge needle docking technique. And by doing it that way, I don't have to grab the haptic, because every time you grab the tip of the haptic, it can deform the haptic and render it unable to cannulate through the needles. And then I go ahead and start with the trailing haptic first, which enables an easier cannulation. It's just more ergonomically easy to do. And so you'll see this execution of my Yamane technique. And so this is a patient. You can see the pupil is a little eccentric. You can see posterior synechiae on remnants of the posterior capsule there in multiple places. So I'll have to lyse those adhesions. I first use a Wexel sponge to dry the surface of the eye. And then I use a tip of the cannula that has been inked, and I use that cannula to mark the limbus, first on the right side and then 180 degrees apart on the other side, using the cannula to find 180 degrees apart. To me, this is the easiest way, kind of the eyeball technique, just kind of go in low mag and then find 180 degrees apart, and this has served me well. And then I use a fixed caliper. You start 2.5 millimeters radial, make an indentation, and then 2 millimeters adjacent on the right side and then the left side, and then using the cannula to mark both sides as well. Again, using the cannula just creates nice and distinct marks, and I really like doing it this way instead of marking the caliper directly now. And always, again, dry the surface with the Wexel sponge. The cotton tip is better to hold the eye, so I'm using the cotton tip to control the eye for my incisions. First, the contralateral limbal incision, and then that second incision is for my AC maintainer. And then these are just my incisions if I need to do any further manipulation, vitrectomy, etc. Again, this patient has had a vitrectomy, so I will not need a trocar for this case. This is some intracameral epinephrine. And as I do this, I'm trying to lyse those adhesions of the iris to the posterior capsule. And this is dispersive viscoelastic to coat the corneal endothelium. And this is the 3 millimeter blade. I'm going to make the incision, again, perpendicular to my marks and contralateral to that limbal incision. And once I do this, I go ahead and place the sensor lens. I have placed cohesive viscoelastic into the barrel as well as on the platform. And then I'm going to place the lens and seat it into the platform, bringing the wings together. I make sure that the optic bends concavely away from me, and then making sure that the leading haptic comes out straight through the barrel, and then the trailing haptic comes out. Go ahead and place it into the injector, making sure that the trailing haptic is outside of the shaft of the barrel, and then push the plunger down and advance the lens. So here we go. This is a 25 gauge needle. You can see that there's BSS coming out, and that's because it's loaded on a syringe full of BSS. And you want to bend that 25 gauge needle so that the bevel is facing to the right. And then again, I'm showing you the right side needle, and this is how I'm going to hold it. And the bevel should face towards me. And then the left side needle, the bevel is going to face away from me. And here we go. This is the 25 gauge needle placed through the contralateral limbal incision. I place the injector into the eye. My surgical assistant is advancing the lens and the leading haptic is coming out. As it comes out, I ask her to stop, and then I'm able to direct the needle so that the haptic is internalized into the needle. And as the lens is advanced, it goes in further. I'm able to withdraw that needle, and then the haptic is out. I stop. And then I take over and make sure the optic comes out flat, and then the trailing haptic is pointed to the right. This is the Lewicki 20 gauge AC maintainer. You need a tight fit, and sometimes you have to widen the incision, so be mindful of that. Activate infusion. This is key. You activate the infusion when you have to place the needles in the sclera. If you don't, you'll have poor control of the eye. Hold the eye in the neutral position with forceps, and then start with the first mark. Make sure you stab into the sclera, not just the conjunctiva. Advance 2 millimeters and dive down. Make sure you avoid the ciliary body. And then now, I can stop infusion if I need to, but I go ahead and place the haptic into the eye with microforceps, dock the haptic on the bevel of the needle, and it goes in really easily and quickly. That one went very smoothly. Go ahead and disengage the needle from the syringe and then lay it down very carefully. You want to make sure that it doesn't cause the lens to kind of turn in a strange way. So you lay it down and then internalize the leading haptic and lay it into the angle. Sometimes you can see internalizing of the haptic into the needle is really fast, like it showed on that trailing haptic. Go ahead and activate infusion, grab the incision. Start with that first mark. You definitely want to stab into the sclera, tunnel 2 millimeters, and then dive down. Again, it's very important that you don't just stab in the conj. You need to stab in the conj, and then that same spot, stab into the sclera at the same time. It's such a subtle point, but it's very important. You got to stab into the conj and then into the sclera, but then you have to understand the nuances of how deep you're supposed to go with that needle and the angle in which you go. That's really the subtle parts that's really hard to articulate sometimes, but that's how you're able to get that nice scleral shelf. Again, you can see the borderline pupil. I'm able to pronate my hand, try to get that bevel aligned on that needle with the haptic, flattening the haptic out. I'm right at the edge of my view, but you can see I'm flattening out right there, and then now I'm feeding it. So I got it. Okay. And so again, with the sensor lens, it doesn't tend to slip out, and so I don't really have to put too much in, so I feel really confident. Go ahead and make sure that right needle is not sitting funny, and then start to pull out that left side needle, pulling it towards me, and then having the microforceps ready to grab so it doesn't slip. Again, with the sensor lens, haven't really seen it slipping, and then cauterize the tip. You always want to be prepared though, so get that forceps ready to go, hold it right there as you pull that needle out. Again, the right side needle you're going to pull away from you. Pulling it away, grab the haptic so it doesn't move. Very gently though, you don't want to crimp the haptic, and then transition to cautery and cauterize the tip. Sometimes when you have the water on, it'll prevent the cautery bulb to form, so you can sometimes have to just turn off the water or just dry it off with the cotton tip or some wax cell sponges. And again, you can see how flat the profile is of the haptic to the sclera. Go ahead and push the haptics into the sclera and reapproximate the conjunctiva. And at this point, you can reactivate infusion. This is the surgical PI. Because this is an awkward angle, you see how I'm using the AC maintainer to hold the eye and center it. with counter force. You see that? So I did that as a nifty maneuver using the AC maintainer, holding it in position as I'm trying to make that PI. Again, there's a little bit of an Orlock phenomenon because of where I'm angled, but I held that AC maintainer to keep the eye in the neutral position. Again, a little neat trick showing you there. Sometimes you have to get creative when you're doing surgery. This is some intracameral Kenalog. As you can see, there's really no vitreous at all. Haven't encountered any vitreous throughout the entire case. Again, this patient had a vitrectomy from a retinal specialist. But again, you never know, so you never assume. Go ahead and place a 10-0 nylon suture over my main incision. Again, you don't want to take a chance and have vitreous at the end of the case. Hydrate my incisions, making sure all the viscoelastic is out of the anterior chamber. What a beautiful case. This patient did so well. Hydrating the incisions, I'll take the AC maintainer out, and that's the end of the case. You can see a perfectly centered lens. You saw, again, a nice flat profile of the haptics when I got done with externalizing the needles. That tells you I have a nice scleral shelf, which provides support of the haptic to keep it flat, and therefore the optic is going to be in proper effective lens position, the way it's supposed to be intended, which is supposed to simulate the capsular bag. Again, if you have the flagpole sign, which is what I call it when you withdraw the needles and the haptic is pointed towards you, if that happens, that means if the haptic is pointing up, that means the optic is pointed down. And so you're going to have tilt, you're going to have a sagging optic, and that's really bad technique. That should be a sign to you that you've executed a poor scleral tunnel with the needle. And so that's so important. And again, I cannot overstate how many times I've seen videos online where the haptic is pointed up at the end. And so you might feel good about yourself because you're looking at it two-dimensionally and you think it's fine. But the truth is, if you look at it at the slit lamp three-dimensionally, that's probably when you'll notice that there is tilt to the lens. You can see there's a little bit of capsule that's there flopping around. And so I go ahead and do a little bit of vitrectomy, removing that capsule that's exposed right there. Again, it's not vitreous, that's just a little bit of that capsule remnant. So I go ahead and take the AC maintainer out now. I had to take it out and put it back in because I saw that flopping capsule, and that's the end of the case. Again, externalize the leading haptic, use a 25 gauge needle docking technique, as you saw. By doing it that way, you're not having to grab the haptic. Go after the trailing haptic now because now the optic is pushed away from you because the leading haptic's externalized. So it's much easier to cannulate the right side needle through the trailing haptic this way. As you saw, it took like 2 seconds. It was so fast. And then you can go after the left side, the leading haptic, and then performing the Yamane technique. Again, the sensor lens does not tend to slip. And so I love this lens for that reason. This patient ended up with 20/40 uncorrected vision day 1 after surgery. She was very happy. But, the other eye had an uncomplicated cataract surgery. So, of course, the first words out of her mouth were, I saw better with my other eye day 1 after cataract surgery than this eye. And, of course, I had to explain, well, that was just a routine cataract surgery. We have a lot of people who see 20/20, 20/25, 20/30 after surgery for routine cataracts, but this was not a routine cataract. This is a complex secondary IOL surgery, and for you to see 20/40 uncorrected at day 1 is actually a very good result. Again, she wasn't being critical, but it was, again, just a kind of a natural observation. Again, this is not a refractive surgery by any means. We're not trying to necessarily achieve 20/20 uncorrected vision. However, if you properly execute this surgery the way I've shown, you're able to get a nice scleral shelf for the haptics. Therefore, you're going to have better effective lens position and more appropriate anatomic positioning of the lens, which is supposed to simulate capsular bag positioning of the optic. and therefore you're going to have better refractive outcomes by utilizing the principles and techniques that I've shown in this video and all the videos in the past. So I hope this was helpful to you, and I thank you for your attention.